real quick, rapid fire GI bleeding, okay? So 2 classifications, upper versus lower. Where's the cutoff? Well, the ligament of Treitz. And what does the ligament of Treitz do? Well, it separates your duodenum from the jejunum, terminal ileum, large bowel. Okay, so this is separating the two. So peptic ulcer disease is our big issue here. So you have maybe some gastritis or perforated gastric ulcer or duodenal ulcer. So that's going to be what's causing bleeding. So the duo is an interesting one. Any of those can bleed, causing upper gastrointestinal hemorrhage. However, if they perforate anteriorly, that's more likely to then cause intra-abdominal sepsis, if you will, or purulent peritonitis because of the free perforation. Whereas the duodenal ulcer that perforates posteriorly, the thing we think about here is it eroding into the gastroduodenal artery. Okay? So we treat these things with upper endoscopy or IR interventions, right? An IR can come and do an angioembolization of like the GDA, which would be most common. Or eventually, if they're still hemodynamically unstable, being resuscitated, they come to us for surgery. Or if they perforate, they would need surgery, okay? Lower GI bleeds, a little bit different. So what are some examples? Well, tick, right? A diverticular bleed, colon mass, AVM. I don't know, you guys tell me some more diagnoses here. And we kind of work these up a little bit different because we could do a CT angio or a bleed scan, okay? And then we could move to a formal angio, but we also would do endoscopy to take a look, okay? So upper GI bleed, lower GI bleed managed a little bit differently. Up here, we have to make sure we start a PPI or Protonix drip typically. And then we can do prophylaxis with Pepcid, but the mainstay for the actual acute setting in a gastrointestinal hemorrhage would be your GI bleed. Another good one up here would be like a esophageal varice from portal hypertension. That's another very scary one. And someone asked me too about like a Blakemore. We've only done those a handful of times, but they do work where it's a special type of nasogastric tube really that has a gastric balloon and an esophageal balloon. You blow up the gastric balloon in the stomach, and then the esophageal balloon is going to tamponade the bleeding there. But that's a really rare situation, and it is a major problem. But peptic ulcer disease is going to be your mainstay there. And this obviously can be from a gastric mass as well, something like that.